All right, let's dive deeper into this case because this is a really interesting one and gives us a lot to talk about. We've got a 20-year-old male presenting with right flank pain. And of course, whenever we hear flank pain, one of the first things that come to mind, especially in a younger patient, is a potential renal issue. Now, the patient underwent a contrast-enhanced CT scan of the abdomen, and there's a lot of important information to dissect from these images. So let's walk through the key findings. The most striking thing we see is a 5-centimeter lesion arising from the renal cortex in the lower pole of the right kidney. That's the focal point here. And right off the bat, this lesion has some really characteristic features. First, it's eccentrically located, meaning it's kind of off-center in the kidney, and it has well-defined margins. Now, well-defined margins are something we always like to see because that suggests it's likely a benign process. And then, looking at the density of the lesion, this is where things get interesting, it's predominantly fat density. When we see fat density in a renal lesion, one of the first things that comes to mind is angiomyolipoma, AML. AML is a benign renal tumor made up of 3 components: blood vessels, angio, smooth muscle, myo, and fat, lipoma. The presence of fat on imaging is such a hallmark feature of AML, and it really helps to narrow down our differential diagnosis. But remember, not all AMLs contain macroscopic fat, which can make things a bit tricky sometimes. Looking at this CT scan more closely, we also see serpiginous enhancing vessels within the mass. This enhancement pattern tells us that the lesion has a rich blood supply, which is typical for AML because of its vascular component. Another reassuring finding here is that there's no evidence of perinephric or retroperitoneal collection, meaning there's no fluid or blood collecting around the kidney, which is something we'd worry about if this mass had caused any bleeding. Speaking of bleeding, let's quickly touch on that because it's a key concern with angiomyolipomas, especially when they get larger. This lesion is 5 centimeters, and lesions over 4 centimeters are at higher risk of bleeding, particularly into the retroperitoneum, which can be life-threatening if not managed. Fortunately, there's no active bleeding here, and that's always a relief. The scan also didn't show any signs of adenopathy, meaning no enlarged lymph nodes were found. That's another important detail, because the presence of adenopathy could suggest a more concerning or aggressive process like malignancy. So the absence of lymph node enlargement is a good sign here. One additional finding we see on this CT scan is a subtle low-density lesion in the right lobe of the liver. Now, this is something we'll want to keep an eye on, but it's not an immediate red flag, especially in the context of a young patient with an otherwise benign-appearing renal lesion. It's likely an incidental finding, but follow-up imaging will be necessary to make sure there's nothing more to it. And lastly, we've got some simple cysts in both kidneys, which are really common and typically benign. They're not something we're too concerned about unless they show unusual features like thick walls or septations. But in this case, they appear to be just simple cysts, which are very common and typically harmless. All right, now let's break down what this all means. The imaging findings: the 5-centimeter fat-containing lesion, well-defined margins, and serpiginous enhancing vessels all point strongly toward a diagnosis of right renal angiomyolipoma, AML. This is a benign lesion, but because it's over 4 centimeters, it does carry an increased risk of bleeding. So what's the next step? Well, the management of AML largely depends on the size of the lesion and whether or not the patient is symptomatic. Since this lesion is 5 centimeters, we're entering that territory where we need to start thinking about preemptive treatment to prevent bleeding. Preemptive selective embolization would be the likely course of action here. This is where we go in and block the blood supply to the tumor to shrink it and reduce the risk of future bleeding. It's a great option because it's less invasive than surgery and has a good track record of success in managing AMLs, especially in cases where we're trying to preserve as much healthy kidney tissue as possible. Now, it's important to note that embolization isn't curative. The tumor doesn't completely go away, but it stops growing, or at least slows down, and its risk of bleeding is dramatically reduced. If embolization isn't possible or effective, we might consider a partial nephrectomy, especially if the lesion shows signs of rapid growth or if the diagnosis is in doubt. Let's talk about the differential diagnosis for a minute. While angiomyolipoma is the most likely diagnosis, other fat-containing renal lesions should be considered, including renal lipoma, fat-containing renal cell carcinoma, which is much rarer, or even liposarcoma. However, the imaging characteristics here are classic for AML, so these other possibilities are lower on the list. Now, angiomyolipomas can occur either in isolation or in association with a genetic condition called tuberous sclerosis, TS. About 80% of AMLs are sporadic, meaning they occur in people without TS, and they tend to affect women more than men. The remaining 20% are associated with TS, and in those cases, we'd often see multiple and bilateral AMLs. When we encounter multiple AMLs, particularly in a younger patient, it's a good idea to look for other features of TS, such as brain lesions, like cortical tubers, or subependymal nodules, retinal hamartomas, or cardiac rhabdomyomas. But in this case, we don't have any evidence of tuberous sclerosis. The patient's pain actually resolved, which is great, and the urologists have planned for serial ultrasound scans to monitor the lesion going forward. Ultrasound is a great tool here because it avoids the radiation exposure associated with CT, which is especially important in younger patients. So in summary, we've got a 5-centimeter right renal angiomyolipoma with no signs of acute bleeding or concerning features. The plan is preemptive selective embolization to reduce the risk of future complications, with serial ultrasound scans to follow the lesion over time. This patient is in good hands, and with appropriate follow-up, we can ensure they remain asymptomatic and avoid any serious issues down the road. And that's a wrap on this case. If you're enjoying these deep dives into radiology cases and want to keep exploring more fascinating topics, make sure to subscribe to Radiology Made Easy. Don't forget to share your thoughts in the comments. And if you think this episode could be helpful to someone you know, feel free to share it with them. Oh, and if you want to support the channel and help keep this content coming, you can buy us a coffee through the link in the description. It's always appreciated. Thanks for tuning in, and I'll see you in the next episode.